Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with John. How you doing today?
Doing pretty good, Dennis. Thank you for inviting me to be on.
Hey, my pleasure. I'm super glad that you jumped on. Since this is the first time on the podcast, would you mind just doing a real quick introduction of yourself?
I'm John Dominguez. I had a 20-year career, 17 years that was in special operations. After I retired, I worked in industry for about 7 years, and then I was Secretary Treasurer for SOMA. I did on committees back when I was in E6, and I also I'm currently the immediate past president for SOMA for another year and a half. And then I'm also currently the honorary sergeant major for the Army Medical Department Regiment.
Awesome. Well, very accomplished. But SOMA is what I'd like to talk about, and you have lots of experience in that organization. So maybe just start off real broad. What is SOMA? Who do they represent? Kind of give me the spiel there.
Sure. So it's kind of an interesting story. Back in 1987, at the time he was Major Stephen Yevich. He was command surgeon for the John F. Kennedy Special Warfare Center School, and he was basically given an order to start a proof of concept between 1987 and 1988. And the proof of concept was to develop and host an annual Special Forces medically focused meeting and provide updates, because as a regiment, people became fragmented. Certain people were going to certain schools, certain people were doing other things outside of the special operations medic course for and SFMS, which at the time was in San Antonio, and it was course number 300 F1. And they wanted to make the soft medics or SF medics at the time interoperable. And so they wanted to have that baseline. And then in 1992, USASOC kind of stood up, and they liked the concept. It had been going on for a little while, but they wanted to take it a step further in that they wanted to make it international. So it became the Joint International Special Operations Medical Conference. And this was all put on the surgeon cell to put together, which was a huge task. And one of the things that I think he was a lieutenant colonel at this time, Stephen Yevich, and several others like Craig Llewellyn and others realized is that it's almost a full-time job. And then so they got more staff. They tried to maintain it, but then in honestly around 1992 to 96 is when they realized that they needed to push towards a nonprofit, because there was really no way for them to do both missions. And the JAG started having some issues with cost, travel, because we were paying for international and other people, and other forces to come in for this, so that they'll start getting pretty large outside of the normal operational budget. And so they went ahead and started the nonprofit. And when they did that, they changed it to the Special Operations Medical Association. But originally it was targeted at creating interoperability. And then in the 90s, USASOC gave guidance. They wanted it to be international. to be interoperable that way. And then over the years, especially in 1999 to 2001, we had a British officer that was president of SOMA. So we have had an international officer that was president at one time. So we've been tied with the international medical community for years, but through the last 20 years of conflict, it has grown exponentially. This past year in 2025, I believe we had between 32 and 37 countries represented. And currently we have our international track that has gone on for well over 15 years. Alan O'Brien and Sandra Heinrich Rabbit took the reins on that for several years. And now Rabbit is on the SOMA board as the secretary treasurer. So he did 2 years as a board member, and now he's secretary treasurer, which is it's great to have because he brings a lot of influence and interest from the international community, not only from the NATO countries, but we have a lot of Indo-Pacific allies that come in as well. And so the core of interoperability is still there. And when it started, it was to, and it was kind of funny because the Ranger Regiment had this problem for a while. 3rd Battalion would do something, 1st Battalion was doing something else, and 2nd Battalion was doing their own thing. And there had to be some standardization on the medical side, which once the regiment got more solidified, they were able to get their evaluation program stood up. But when you're trying to do this with all of special operations, it's a lot harder. A lot of different missions, what commanders and what see as important and what's needed, and then the time frame they're willing to lose somebody for. The refreshers become an issue for certain commands and certain components. But over the years, SOMA has adapted to what SOCOM and what the global SOF community has kind of needed. And we've exchanged, and the best thing is it's kind of been therapeutic in some ways, in that during the years of conflict, you would go to SOMA and you would see people that you hadn't seen since you were either in school with them or that you hadn't seen since you were in country with them, both internationally and sister service wise. And you get to decompress and talk about things that you guys have seen and done and exchange ideas. And one of the SOMAs I remember from the early 2000s is there was a SEAL, a recon corpsman, 18 Delta, and a 160th medic that came in, and they had their aid bags, and they each gave a briefing about their aid bags and why they packed the way they packed because they're mission sets. And so you got to see a lot of different, some people would carry more something, some people would carry less of others. And obviously with the 160th, they had an airframe they could carry stuff on. So the aid bag was packed a little bit differently than what some of the others that didn't have, a mobile vehicle there, aircraft. But one of the things that's in the SOMA bylaws is that we attempt to have 50% of the presentations to be medic driven, because one of the other interoperability issues that was trying to be addressed is in the Army, and I know this happens in the Navy, you will get a surgeon that comes over from the General Purpose Force, and they are unfamiliar with or have no experience with special operations medic and what that medic is able to do and what their training is like. So SOMA also provided a way of showing the competence of the special operations medic, and it also helped to evaluate younger or junior medics, because if you go overseas to teach, you can give your classes here in front of your peers and get feedback. And so it was all about professionally developing and continue to develop um, uh, both enlisted and officers, and be able to get them to work interchangeably. So, and if you look at the 160th, if you look at the Ranger Regiment, there's so many different avenues of special operations, to where it's like, um, if it's just you and your surgeon, it's like, okay, you want day shift or night shift, until we get everyone else here. But you become interoperable in several ways, and this was to, in a very short period of time, build that rapport. And then over the years of conflict, um, it's one of the soft truths. Special operations cannot, um, work solely. We need the help of, general purpose force, maybe, host nation or partner nation forces. Um, so the more that we brought in, it was to help expand not only education, but opportunities, not only for education, training, and then understanding of different protocols, procedures, things of that nature. And things that we would bring in that um, we didn't think of ourselves. And if you look at one great example is ultrasound. A lot of people got trained in ultrasound, and I've seen some people that, some medics that are very good at it. You turn the patient on their side, a lot of them lose their landmarks. So why would you have a patient on their side? Well, if they got abdominal trauma, but they also got their back burned because of an IED, you're not going to lay them on their back. So now you have to look for what's abnormal, but you don't have the normal landmarks. You might have mastered the skill with the person in a, supine anatomical position. However, you didn't master identifying, the organs, and shift depending on, if they're right or left, they're laying on their right or left side. So at that point, it doesn't matter if you have an ultrasound if you can't find what you're looking for. But if you would have rolled that person on the back, that they would have, had no issue. And it's hard to maintain skill sets like that when you've got to maintain so many other insertion methods. You got to maintain weapons proficiency, language proficiency, writing reports, sit reps, training schedules, refresher. There's just so many tasks. Yeah. Being able to have SOMA with that interoperability allows for a soft medic, given it any flavor, to be able to assist another soft unit in case their corpsman or medic goes down. You're going to have the baseline, or if you're heading off to someone, you've got that baseline of interoperability. And I think that in this last 25 years of conflict, we definitely saw that transfer of interoperability happen in the general purpose force. And I remember Dr. Mayberry wrote a paper, I want to say it was around 2012 or 2011, where he discussed how qualified the National Guard and Reserve were, and how many paramedics they had versus active duty. And the transfer of care was actually better if you got a National Guard or Reserve medevac. So if I had to say three things about SOMA, it's networking, relationships, establishing interoperability amongst global soft forces and civilian partners, because we exchange and build resiliency within our local communities, and we're able to both grow together and help adjust certain treatments like blood or hypertensive resuscitation, and be able to practice those and be able to get them accepted by the civilian side or by the military. And then the last one goes into the mentoring, both of uh, medics, but also officers and researchers, because most of the researchers definitely haven't seen um, an aid bag from a SOF MES versus a general purpose force MES or a Navy AMOL in special operations versus a IDC AMOL or a sub IDC AMOL. So it gives them the opportunity to see some of the devices and the size, weight, and cube. So it becomes more real to them that we can't carry everything that we'd like to or that we would need. We have to make our best guess and have items that can be used for multiple different things.
Yeah. Yeah. Like when I've gone to SOMA, it's almost like you kind of took the best parts of Refresher. So like you get to see people you haven't seen in a long time. You get to chat and find out what other units, other people are doing, without any of the pressure of being under the gun and losing your certifications, right? So you get to get updated on things, right? Like the refresher courses, you're just trying to get people up to an acceptable level, and that's about as far as you can take them, outside some tips and tricks kind of things. But since you don't have that problem at a conference, they can go as far as whoever wants to talk and teach can do it. And you can do that on like an international level. So, what you aren't able to get at a refresher course, like the experience from, a large number of international folks, military, civilian as well, people who've been to conflicts that America, the U.S. is not part of, so you get to see things from Indo-PACOM or Eastern Europe or South America or whatever. And these people show up for the same reasons the U.S. guys show up, just to get refreshed, to meet and mingle and learn. And you do that at scale at SOMA.
And one of the things I forgot to mention, I couldn't tell you when they started, but the labs are extremely useful. It's a great refresher. It's a great introduction. In years past, we used to have battlefield acupuncture. I remember in the early 2000s, we did it. I know for whatever reason we stopped, I think around 2006, but we would do refreshers on nerve blocks. And so, of course, depending on which one you did, you'd see guys limping to the bar, to the restaurant afterwards because their leg was numb. And even with dental and some of the non-trauma modules, that it makes it easier for you to maintain your training requirements. There has been, and one of the great things too is, so I think the first one I went to was in 1997, and I was a E5 at the time, I think, and I'm listening to Dr. Holcomb speak and Frank Butler and so many people, and I thought to myself, this stuff is well over my head. And it was funny because I was there with a couple of surgeons from the JMAO at the time, and they explained certain things to me. And so it started making sense into what we were, they were talking about. They were talking about concepts that, about the hypotensive resuscitation. And they were talking about, or we're like, wait a second, they just drove home that it was 2 large bore IVs. and they just, so it kind of contradicted some training as Interoperability ended up being very controversial initially. And then I had the privilege of going to Ben Taub in Houston, Texas, and working with Dr. Holcomb and Dr. Ken Maddox, and seeing it in the hospital firsthand in Houston, of how well it worked. I was immediately sold on it. But it's funny, the concepts that you think like this goes against what we were taught. I learned, what I took away from that is there's many ways to do things. And once you understand the anatomy and you understand what's going on with the patient, and your time frame that you have and whatnot, you can relax and do things. Because before then, I was so used to algorithmic medicine. And I remember when I was an instructor at the schoolhouse, guys would graduate, and I would tell them, okay, you've completed the requirements for this course. Now you're going to actually go out and practice and learn how to do medicine. Because unfortunately, we have to have an equal grading standard, and it's got to be fair across the board. We can't change it as often as we would like to, or as quickly as we would like to. But when you leave there's a whole big world that you still need to learn and pursue. And you have some people that realize that, and they study on their own, and they take every opportunity to advance their medical knowledge, which SOMA helps to assist with. And you have others that are kind of like, well, I'm just going to do my 2-year refresher, do my on-trial modules, and go back to the unit. And I always tell people, if you look at like BCT3, how they would go and do a pre-deployment training for a lot of the general purpose force. It was almost like just-in-time training. And I always had a problem with that because, as a father, a mother, a sister, a brother, you don't want somebody working on you or your loved one that had just-in-time training. And I don't think there's ever been a study to show what the retention level of a 2-week just-in-time medical training course actually produces, the results that it produces. But the only way to get ahead of it is to take the time now to anticipate and cast our net wide as far as knowledge, and then you'll have the resiliency to make the right choices. And if you know the basics of how, like for instance, a tourniquet works, how the width needs to be so you don't cause a palsy, different pressures, size and clothing that may come into play, then you can improvise a commercial device. And in the future, where we might have contested logistics, there may need to be improvisation. And a lot of people have said, recently, well, you don't want to go, and improvise something. Well, no, if I have the perfect device, I'll do that. But I think you and I grew up in the realm where it was kind of like, you're going to put this, you have the bandage. If that doesn't work, a pressure dressing. If that doesn't work, you'll find a stick. And I didn't question it at the time. And then I realized, like, there might be some places that I'm not going to have a stick. So I went to like Home Depot or something. I bought like wooden dowels that, I kind of use that. And then when I went to the course, it was like, oh, you got to make your own improvised tourniquets. But it went into the basic principles of what you needed to do. And when I went through at the time it was the 9-1 Bravo course, they didn't teach you the principles and the adverse outcomes if you did this incorrectly. But those are the types of things that when we look at the basics, we need to create medics that have a secure fundamental base in anatomy, physiology, and what the devices that they're going to be using, interventions they're going to be doing. what can they expect, especially if they have to hold them. I was taught to put in a chest tube, to take out a chest tube, put in a crike, take out a crike. But what if you've fallen on a patient that has a drain? It's been in there for 3 weeks, probably time to take it out. How many minutes you're taught on how to do that with different types of drains? I remember there was a time that they were teaching us how to do X fixes, but that was one of the things, that was a skill set that, is it possible? Sure. But there's no way to keep up that skill. And it's all about repetition. And that's where, right now, I think we've become very, very good at trauma, but when it comes to the nursing aspect, when it comes to the long-term care or DMBI, we don't have enough repetitions on those things. The PSC addresses a little bit of that, but when it comes to nursing, it's a time-consuming thing to take care of sick patients. And when you look at the a year, 2 years, 3 years, the time frame just isn't there. And so SOMA gives you that, it's almost like the cliff notes of a myriad of medicine, everything from human performance to research that's, coming out in the next, 5 to 7 years, all the way to trauma. And then every day there are vignettes to set the mood and learn from what other people have done. Or one of the things I love about the special operations community that you don't see at other medical conferences, we actually talk about our failures so other people don't make them. Whereas at other medical conferences, you really only get briefed on the successes, and you learn more from your failures than you do your successes. And really intelligent people will learn from other people's mistakes versus, making their own. I mean, you'll learn from yours, but someone gives you the opportunity to learn from other people's. And the collaboration and the friendships and network that you make is with higher ranking officers that may not be in SOF, but the information they have and outlook directly impacts SOF, and it can, you end up seeing joint papers that come out of it, and then the international community as well. So one of the biggest problems that I've seen over the years is there's a lack of medics that submit abstracts for presentation. I think this is kind of a twofold thing. One, it's extra work, and there's got to be some type of motivation. I know during the war, a lot of us were motivated because we were losing our friends. So we wanted to figure things out and we wanted to make things right. The limitation of SOMA being able to have medic presentations is the limitation of the submissions that we get. And on the website, we've got an information at specialoperationsmedicine.org. And if people shoot a message saying, hey, I'm interested in shooting an abstract, I need some help, or could I have somebody review this? One, it'll up your chances of it getting presented. And two, it'll help you with the process, because we want to have more NCOs present. One of the other things I see with people is a lot of medics have almost like an imposter syndrome, because all of us know people that have done way more, or they are better at this or better at that. But if the story doesn't get told and shared, then it doesn't matter that someone else knew more or someone else did more. No textbook covers experience, and that's where the vignettes come in, but also presentations. Yes, you might have an N of 1 or N of 2 anecdotally, but they're little tacit pieces of knowledge that may get overlooked. And back in 2003, We didn't have uh, needle decompression needles that were specifically for decompression. We'd use regular, angiocaths. Um, you have a 3-year-old kid that has a bilateral, what's it called, lung collapse, and you need to go ahead and decompress or put a chest tube in. Well, you get that little 3-year-old barrel chest. That 18 gauge needle is kind of, long, and, if you're not sure about the anatomy where the heart is or the lungs, you could do some damage. Uh, However, if you know that, you're in a situation where if I got to do something, um, dissecting down, if you know that anatomy, you might be able to do it. And then guess what? If you're not packed for child trauma, what else can you use? A Foley catheter, you know. And when you think about the intercostal muscles, are they strong enough to, at that age, to compress that Foley catheter? Do you happen to have a Christmas tree that you can hook up a Heimlich valve to? Or if the Heimlich valve is too much, slide a glove through and have the glove be the Heimlich valve, because it doesn't have as much pressure, and try to use positive pressure ventilations to re-inflate the lungs. Those are the things to where you have to be on site and try to think quickly through the process and all the anatomy that goes into it, what you're actually trying to do. And can you get that? If I bring this child back, do I have someplace to take him? At the same time, you have, sometimes, depending on the thing, you might have no one, or you might have a crowd of people watching you, looking to see if you're going to do something. So there's a lot of different facets, and I think that medics that don't tell their story, they kind of they leave room for others to make mistakes, or not have the ideas to think outside the box of some of the algorithmic medicine they were taught.
Yeah, I think that's one of the great things about the vignettes that you get at SOMA. We used to have something very similar at refresher courses. You have a much smaller audience, right? But SOMA, you get a much larger audience, and those vignettes, I wouldn't say necessarily if this is how things need to be done, or this is what to think when this situation approaches, but you definitely get to see the mindset of a medic in a situation, and this is how I thought my way out of it. And that's when you get to those improvised things, or how I had to adapt, my supply or the environment, or what, in order to get out. The odds of you ending up in a situation exactly like that, 50-50. But how a medic thought his way through, or a doctor or whomever thought his way through, like, that's where the gold is at. Yeah.
Absolutely.
So, and we mentioned labs. Obviously, there's presentations, but like, what kind of things are offered at SOMA, just so people can kind of get an overview?
So there, of course, we do dental labs every year, because that's part of your non-trauma modules. But there'll be hypothermia labs. Now, when I say hypothermia labs, they will discuss hypothermia. They'll discuss rewarm you. But unless you go to Denmark, Finland, or Norway, they do hypothermia labs where you're going to go hypothermic. That is a whole different experience. Just like experiencing shock, if for those that don't climb and go to altitude, and you see what you're, when you're setting, in 85%, how winded you get, how much you're able to carry, how you're able to operate. Those are things that can be discussed there at the conference, but until you experience them, so it makes the learning connect. But it also tells you, with some of the people that put those on, that they tell you about opportunities that you may have for training in those environments, both here in the U.S., in Alaska or up in Vermont, or the NATO courses that are put on through a contract that NATO has with the University of Cork in Ireland. And there's several courses that they offer that are available to U.S. members. A lot of people don't know about them, but they're definitely worth going to, and you can get a different perspective. There again, all of those courses, yes, you're going to get a certificate. Yes, you're going to get actually the University of Cork, you can get some college credit, but they're not going to be part of the U.S. professional development model. But with the labs as well, you have canine labs, you have ultrasound labs, you have cadaver labs. There's I think for a while we had maggot labs. We did leech, microwave leeches. Of course, there'll be blood and blood therapy and component therapy labs. So
they had airway labs,
airway labs, yeah,
airway labs, vent labs.
And one of the great things about some of the new equipment training is you can see different things that may come out or that you may see somewhere else on the battlefield. Because if one of the great things and one of the bad things about having so many different devices out there is that it causes you to have to learn so many devices. Now, granted, you have a lot of great choices, but if you don't know how to put them in operation quickly, effectively, then you're kind of dead in the water. It doesn't matter how cold the item is. And that was one of the things that's great about Refresher is that for a while there, and I don't know if you guys still do it, you could either bring in stuff or you guys would already have a bunch of different items to try to utilize. So that way you wouldn't order something and try it out for the first time.
Yeah, we try to do that. We go through obviously the government has their paperwork that needs to be done, but we get several devices and we just make them available if people want to try them out on their lanes, just to play with it, etc. But to actually get to use it and see how it goes.
Absolutely. And one of the great things too about SOMA, if you look at 2023, we had around 1,300 attendees. And then 2024, we had 1,600. And then this past year, we dropped down to around 1,500. But we're also competing with Soft Week. And for the next 3 years, anyway, we won't have that competition. And I know one of the questions that always gets asked is why don't we combine with Soft Week? Well, if we did that, a lot of medical people would not go because commanders, their sergeant majors, the operations people would all go, and then Soft Week takes up the whole conference center. Plus, they utilize 2 other hotels conference area. The hotel rooms, the space, it would just not be the same type of conference. Not to mention, when you look at the spending of the for conference funding, that would be a huge issue as well. And we still fight that issue with SOMA. And I think a lot of people don't realize that when I kind of stated in 1987 to 92 how much work the surgeon cells had to do to put on the conference, about that same amount of work has to be done, if not more, at the SOCOM surgeon level, because all the components have to give numbers. They've got to correlate them, but pretty much a month after SOMA stops, they start the process of going through the paperwork, writing the justifications, And a lot of times things come in late because SOCOM has a precedent for soft week. SOMA is not a large ticket item for the majority of them. And so it kind of takes a back burner to some of the staff, and you kind of constantly, from the surgeon's point of view, remind them without being annoying or where they don't want to see you. And then you've got to ask for money, ask for resources, even if you program the money in, given the year, if you go into continuing resolution or if you have other fiscal constraints, then it all impacts. And what you have is a bullwhip effect to where the people in groups, the people in, when I say groups, I'm talking both, the SEAL teams as well as, special forces group or any soft organization. The bullwhip effect is you get the snap at the end where you're given almost no time to react. One of the best things that I found is every year when you budget at your unit level, budget to go to SOMA, and hopefully things will work out. And I will tell you that we've recognized this problem for a while. We've tried to address it multiple different ways, and just recently, I think we found a way to pursue this to where it will hopefully solve this problem. Unfortunately, because of the paperwork and some of the stuff that we're going to have to do, some of the relationships and messaging, if we make it happen, it probably won't happen until 2027. And that just goes with the congressional time for submittal. But we have a lot of people that are in support of this. And so I think that we have a very good shot at getting buy-in a lot earlier, and it coming from the Assistant Secretary of Defense level. One of the other things that people have asked and talked about was hotel rooms. So currently, we use 2 main hotels, and then we give options for a couple of others. But the city of Raleigh is doing a huge expansion. They're going to expand the convention center, and they're going to open up a few other hotels and a few more restaurants. It's supposed to be completed late 2027 or early 2028. But that actually outpaces our growth. I think so next year, I think that we're going to see back to the 1600s or more as far as attendees. And we'll have more space. The problem that we always run into is because they give people notification like, yes, you can go a month before. Well, that's when the cutoff is. If we keep rooms or hold rooms past 28 days prior to the beginning of the first person checking in, and people don't pick up those rooms, some has to pay for them. So we have to let them go. And there's like a midpoint where you have to let so many rooms go. So if people don't reserve the rooms early by the time that they get the okay, there probably won't be any per diem rooms left or any at the conference rate. So you can always cancel, but if you want to get into the hotel, I recommend that you make a reservation and cancel it before the drop dead date for you to be able to cancel and get a refund. And then one of the things too that SOMA could not be SOMA and have the conference that it has without the vendors. And the amount of vendors fluctuates. So like in 2023, we had 152. Then in 2024, we had 167. And then in 2025, we had 156 because we were overlapping with Sock Week. So some vendors go there, they couldn't support both conferences, or they supported both, but with a smaller footprint. The money that makes SOMA happens doesn't come from memberships. It comes from the the vendors. So they're a key part of SOMA, and we definitely try to work with them as much as we can. And one of the things that we had not done a good job of is finding new vendors. We always have the same ones. And really, if you look at Soft Week, if you look at AUSA, there are some larger conferences out there that are military oriented, both even in communications, because we talked about telemedicine and other things that we need to capture some of those people that come in and show their technologies. Polaris, they've got 2 vehicles that you can, put litter patients on. A demonstration of that would be great. And so they were actually going to come in 2025, but with the overlap of Soft Week, that's a bigger bang for their buck. And so hopefully in 2026, we'll see them there. But, I would encourage anybody, if you happen to come across a vendor that has a technology or a vehicle or, a drone that can resupply or whatnot, invite them to kind of let them know the website. So that way, maybe they do a lab on, how the drone works, or how to rig the or
Vehicle?
or the I forgot what the razor to be able to carry 2 litter patients, with the little adapters. So that way people can take a look at it and see and get proficient at it. I mean, I remember one year we did a bunch of sked drills because they had the PJ sked, they had the regular sked, and then there was another sked, the water one. So that was a lab one year. So that way everyone can become proficient at being able to know which one you're utilizing, just in case your logistical support ordered the wrong one, which of course we know never happens. The I
You'd
remember.
be lucky if you didn't get a snow sled from the Walmart there.
Oh yeah, I remember one time it's like, well, it's the same thing. It's a skid coat. It's like, no, it's not. It's not the same thing. It's a different model. I can't hoist on this. So, but
So SOMA, I mean, obviously we've been talking a bunch about SOMSA, the conference, but what else does SOMA offer outside of the conference?
So there's a lot of professional development. There's people that may want to go to PA school, people that may want to go to nursing school. We have a very good group of people that are willing to help mentor you, willing to, if there's interest that you have, they can help you get into not just special operations medical committees, but also, like committees within the joint trauma system. Or, if you want to participate and become one of the track co-chairs, you can ask or request to do that, or if you want to become a committee co-chair. It's all about what you want to be able to do and help us try to find your goals. And I know a lot of people haven't noticed, but we always have several universities that are in the vendor or in the expo area, and those vendors are very soft friendly, and they do give a lot of credits for the training and experience that people have gone through, even on the thermal purpose force side, and with the USU School of Allied Health. They even have programs that they offer. And so just hearing some of those are great. Also, there's a field to table track at SOMSA that if you have an idea, they have on that track, they tell you how to develop your idea, how to protect your idea, what the right way is to go about getting permission if you're still on active duty to pursue your idea independently of the DoD, and They can help you with research, marketing. Every year we have the Geneva Convention, not Geneva Convention, Geneva Foundation, and the Henry Jackson Foundation that are there that can literally help you take an idea from concept through testing to manufacturing and commercialization. So there's a lot of resources there for people. And then, of course, one of the things that SOMA does offer, and I mentioned it a little bit before about the mentorship, it's not just mentorship for advancing medical knowledge. Some of it might be career mentorship. And saying, yeah, you can stay in, but the chances of you becoming a sergeant major are very low. There's just not a lot of medics that complete the requirements to become a sergeant major. If you're an 18 series, or if you are a Whiskey 1, you need to leave, in a lot of cases in order to make it to E9 and check some blocks. Unless, of course, you're in a special mission unit, in which case there's some exceptions. But a lot of the experience that's there, I mean, you've got people like Craig Llewellyn that, was there this past year. I was unable to see him, but he's got experience going all the way back to Vietnam. And when you hear about some of the things that they discuss, we kind of get spoiled, and sometimes we walk through life with blinders on. Like, oh my God, my the optics, on our weapon systems from the last team, they were getting rusted in the Philippines. What are we going to do about it? Well, what's your field of fire? How far are you going to shoot? Well, maybe 50 meters max because the tree line's there. Why do you need optics? Well, I'm trying to scope and sight. It's like, wait a second, that makes sense. And it's like, just use your lasers at night. It's like, okay, but you get so focused on using technology that it's almost like you forget. And when you have some of those older guys kind of tell you something that just so simple, it's kind of like, I can't believe I didn't even think about that. But there's a lot of generational knowledge, historical knowledge. Like I said, it's tacit. It does not come from reading books. It's definitely not in textbooks. And so that helps develop the resilience and out of the box thinking. And when I say out of the box, I'm definitely not saying go wild. Mitigate your risks when you start going outside that box.
And so we mentioned SOMSA, the conference, which is obviously the main event and absolutely worth your time if you can go. Obviously, you got mentorship, but just individuals. And as a member, you're kind of in a little more organized way. I know we have the LMS, the SOMED. So helpful about that, if you're a member, is like during the conference, there are 4 tracks going simultaneously. Like, unless you have some kind of superpower or you've divided and conquered who you've gone to, and everybody's taking copious notes, which is not going to happen. You're not going to be able to see it all. You're not going to be able to experience it all. You're not going to be able to get all the little nuggets from all the different tracks. So I think the benefit of that LMS is you put all the lectures on this LMS, and you can just watch the presentation afterwards. So either because you couldn't go for funding reasons or whatever reasons, or because you just couldn't see all of them that you wanted to, through that LMS, the answer is kind of covered.
Absolutely. And it's kind of funny. We've had that LMS for a long time, and now just finally we are able to start making more use of it because of the fact that it was so cost prohibitive to record a lot of the tracks and lectures because of the ease of the conference there. And, thanks to your help and Brandon's and a few others, um, we're able to get that going. And I think that, in this last year, we've really shown an uptake on social media that's a direct result of you all posting those little snips, vignettes, slides, and there's definitely been a lot more traffic as far as questions, and that's one of the great things about SOMA as well is there's little chat groups that start off on the side that really help. If you got a question, ask. Someone may know somebody, or they may have the answer for you. One of the biggest things that there again that we get, I don't want to say cheated out of, but we just don't get taught is, what does it take logistically for us to change the MES? Or if we want A, B, C, or D, how do we get it? And what are things that we can purchase or that we can't purchase? And why is it that the MESs take so long to, a change is made, then 2 years later you get the new, MES update, but then that third year they're already planning for the next evolution. And at the rate of medicine, sometimes what you end up getting issued is already old by that time frame. One example was, at the beginning of the war, you had HemCon, and then it was like, oh, now there are these powders, and you had Celox A, and then you had QuickClot, and just like with all these tourniquets at the beginning of the war. And I don't know when they officially changed the MES from I remember in 2005, when we did a refit, we would get those old green, uh, they're like Vietnam style tourniquets. You had to order the cat tourniquet, the soft TY tourniquet, separately on your statement of requirements. And for soft, that wasn't an issue because we had a statement of requirement that we could put in there. But for the general purpose force, they had to jump through a few more hoops. And there again, that's the type of thing that it's not a soft thing that we were able to do that. There's a process for it. Why does one side have to jump through all these hoops when this other side says, hey, this is what we require, this is why? Why is there such a difference in it? And to be honest with you, if you look at the scale of pricing, yes, it was an increase, but at the same time, you had a lot more studies and you had a lot more wartime uses. So the ability to do that really enhances survival, just like with your hemostatic agents. But at the end of the day, I talked about battlefield procurement, if you're in a contested logistics environment, knowing the basic principles of being able to find the vasculature that is excessively hemorrhaging and putting pressure and stopping it directly, even if it's internal, it still works. So, you can't just throw your hands up if you don't have your specific device or specific gauze that you need.
Yeah, as the casualties mount, equipment goes real quick. So we're pushing up on an hour now. So, is there anything else that we want to get out about SOMA, or like how do I even participate?
So the best thing is to start early, plan for it when your budget is being submitted. And it doesn't matter what side of the military you're on. Everybody forecasts for the next year. Forecast for yourself and others to go. Always overestimate your cost, because if you underestimate, it's going to be a lot harder to go. Know that the SOCOM surgeon's office and the SOMA board of directors is trying every year to make things as easy as possible to get co-sponsored and get more people to SOMA. But one key part is as soon as you get into a medic role, whether it's on the conventional side, whether it's a guard purpose force, whether, um, you're a physician that is even family medicine physician, that is going to be assigned to a field unit, try to get involved early with SOMA. So that way you can progress, become a member. So that way you can take a leadership position, because once you know the history, you know some things that have worked, some things that haven't. And every year poses different challenges for different reasons, some financial, some because of COVID, some because of the war. There was a time when you would have a program and 5 people that were supposed to speak don't show up because they had a no notice deployment. And we would all have to bring extra presentations and try to figure things out at the bar. Like, hey, did you happen to bring, a presentation you can fill in here, fill in there? Those guys that did that, they did it, they had, Excel spreadsheets, and they would cross people's names out, put new names. You'd have to check the board every day to see if the presentation that you originally saw on the agenda was still going to be, still happen. And those things are always going to end up happening. And there's a lot of behind the scenes things that people don't notice. If you notice, a lot of the board or the president, vice presidents, they're always running around because there's always small little problems that pop up. Whether we haven't been protested since we were in Charlotte, but whether it's something like that, or you have, someone who decides they want to assault a vendor or an attendee on their way to the event, or they follow them into the event. I mean, we've had some very, very broad things that have happened, and it's just been crazy. Some of the things that you got to deal with, but that's where you get a text or a call. It's like, hey, can you come up here? We've got a problem. So unfortunately, there's that time frame where you start learning, get involved as soon as you can, and then hopefully you can direct the direction we'll go in. But the key is membership, because if you want to change things, you got to have a voice. And in order to have a voice, you've got to be a member and participate. And the best way you're going to get some of the surveys that get sent out is by being a member. And in order to get to lifetime status, you've got to be a member for, I think it's 5 years consecutively, unless you're employed. And then you've got to also show that you either presented or worked on a committee or a track. But early involvement will definitely help you. And no matter if you decide that you're going to be in medicine for a career, or if you're going to go into business, because if you look downstairs at that vendor expo, you're talking to a lot of people that are in business community. They can talk to you about, going into, different types of businesses, because a lot of times, yes, they might be sales, but there's also engineers, there's PhDs, there's people that have been in industry. There's a lot. And then of course you've got academia down there as well. So there are a lot of opportunities if you choose to take them. And if you have any problems or questions, I refer people always to the website for the information at specialoperations.org. Put the question, the question that you have, in the subject, and then, ask the question. And the Helen, who is the conference, who we pay to manage the conference day to day, or the association day to day, they will direct it to the right people to be able to answer your question and put you in touch. So that way, we can assist you. And that, our basic job, or the reason we do this, is to pass knowledge and to help educate. We all treat our bodies over the years, and what we're left with is our mind and experiences. So embrace lifelong learning as soon as you become a medic or a physician. After you, when you get to a unit, that you have some time to get back, and it will definitely enhance your learning curve. And you might get some great advice from senior people that are no longer, either they're retired or they're no longer at a company level or a battalion level, that may help you with some of the challenges that you fell in on.
Awesome. Well, thank you, John. I really appreciate you jumping on.
I appreciate it, and hopefully I'll be able to see you guys next year at SOMSA.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.